Hi everyone, welcome back to Next Level Ophthalmology. Today is our third class in orbit and we'll be starting with orbital inflammation. It's an important topic with respect to your clinics as well as your exams. So let's start with orbital inflammation. Orbital inflammation can be acute as well as chronic. Acute inflammation, the types are preseptal, orbital cellulitis, orbital periostitis, orbital thrombophlebitis, pneumonitis, and cavernous sinus thrombosis. Under chronic inflammation, we have orbital pseudotumor, Tolosa-Hunt syndrome, chronic orbital periostitis, specific infections like TB, sarcoid, mucor, and actinomycosis. So let's begin with infectious orbital inflammation. Okay, so first we need to understand this concept of orbital septum. So orbital septum is like a guard to the orbit. Okay, so this is the superior aspect and this is the inferior aspect. It is circumferential and it's around the eyeball. So it forms a thin fibrous connective tissue that is attached to the orbital margins and centrally to the edges of the superior and inferior tarsal plate. So anterior to the orbital septum, we have just the skin and loose connective tissue, whereas posterior to the orbital septum, there is orbital fat separating the septum from the contents of the orbit like lacrimal gland, levator muscle, and superior oblique tendon. Inferiorly, posterior to the septum, you may find the inferior rectus and the orbital pad of fat. So this is how it looks from anteriorly. So this is the margin of the orbital rim from where the orbital septum is attached, and it is attached inferiorly and margins of the tarsal plate. Okay, so it converts the supraorbital notch into a foramen which transmits the supraorbital vessels and nerves, and then many structures like supratrochlear nerves, infratrochlear nerve, then lacrimal artery and nerve pierce through the orbital septum. On the lateral and medial sides, you have the medial and the lateral and the medial palpebral ligament. So this is the diagram of the orbital septum. Let's take a question now. All of the following structures pierce the orbital septum except levator aponeurosis. Yes, it does. Supraorbital nerve, we just discussed this. Yes. Infraorbital nerve, no. Infraorbital nerve comes out through the orbit through the infraorbital foramina. Okay. And the expansion of the inferior rectus, yes. So what are the structures that pierce through the orbital septum? We have the aponeurosis of the LPS and the inferior rectus, then the lacrimal vessels, supraorbital vessels, supratrochlear and infratrochlear vessels and nerves, and then superior and inferior palpebral arteries. So these are the structures that pierce the orbital septum. So here it's back for you to revise. So the infraorbital artery and the nerves do not pass through the orbital septum. So there is a staging of orbital inflammation. It's known as modified Chandler staging of orbital inflammation. So stage 1 is preseptal, stage 2 is orbital cellulitis. So this is preseptal cellulitis when the inflammation is restricted anterior to the orbital septum. The next is orbital cellulitis where there is inflammation beyond the orbital septum. Then there is formation of abscess, which is stage 3. So there is a subperiosteal abscess like you can see here. And stage 4 is formation of abscess within the orbit. Okay. And stage 5 is cavernous sinus thrombosis. Now let's understand the differences between preseptal cellulitis, orbital cellulitis and subperiosteal abscess. In preseptal cellulitis, in the first column that you see the infection, the etiology of infection is due to infection of the soft tissue, usually caused by Staphylococcus aureus or Streptococcus pyogenes. So commonly there can be an internal hordeolum or external hordeolum that spreads to the preseptal space. So this is an innocuous condition and it can be treated easily. The lid is swollen and you might find a focus of infection there. The conjunctiva is usually congested and the rest of the eyeball is normal. The treatment is with oral analgesics and antibiotics with topical antibiotics. So, if you feel the patient might go in for a posterior or the orbital spread, you can start him on systemic antibiotics. And if the patient is immunosuppressed, it's better to start systemic antibiotics. So, when does it become orbital cellulitis? So, orbital cellulitis, the etiology is a little different. Okay, it can spread from preseptal cellulitis, but more often than not, the spread of infection is from the neighboring sinuses. So, whenever you are investigating a case of orbital cellulitis, you always want to look at the sinuses. Okay, so exogenous entry can be through a wound or post-surgical surgery like extraocular surgeries, lid surgeries, DCTs, orbitotomies. They can be spread of infection from the teeth, okay, and rarely there can be endogenous infection through the blood. Presentations, it's a little more dramatic. The symptoms of preseptal cellulitis, along with proptosis, chemosis, restricted ocular motility, and there is associated constitutional symptoms like fever. Okay, the treatment, these people require hospital admission with systemic antibiotics, steroids, and surgical intervention might be required if the patient is developing an abscess. So, if there is a raise in the intraorbital pressure, you might want to do a tarsorrhaphy to protect the cornea, or you want to do a lateral canthotomy to protect the optic nerve. Coming to subperiosteal abscess, the etiology is similar to orbital cellulitis, just that it has progressed further and there is a pus collection between the periosteum and the bony wall. So, medial wall is the most common involved wall and the presentation is similar to orbital cellulitis, just that the proptosis increases, it becomes more eccentric, there is worsening of constitutional symptoms. So, the diagnosis is confirmed by a CT scan and the treatment depends on the age group. Okay, many studies have shown that children less than 9 years do not actually require a surgical drainage as the cause is usually anaerobic organisms and they are treated with antibiotics. So, the abscess is usually drained through an orbitotomy under the cover of antibiotics. So let's take a question at this point. A 38-year-old woman presents with painful swelling of her right eye of 1 week duration. On examination, her right eye shows lid edema, congestion, and chemosis of the conjunctiva. Okay, there is proptosis and restricted abduction. She has been advised admission. So you are the resident on duty, and all of the following should be done during her hospital stay. So clearly, this is a case of orbital cellulitis. Okay, so how do you uh, take care of this patient? So you would monitor visual acuity regularly. Why is that? You want to see if there is affection of the optic nerve. Yes. So you want to monitor the pupil regularly. Yes. Monitor intracranial pressure. No. Why is intracranial pressure needed in a case of orbital cellulitis? Monitor body temperature. Yes. So all these points help you to look for the uh, complications that can occur following orbital cellulitis. So the right answer here is C. So what are the complications that can follow orbital cellulitis? So whether it's due to infection, there can be a formation of a subperiosteal or an orbital abscess. And due to proptosis, there can be exposure keratopathy, so the cornea may get damaged. And due to increased orbital pressure, there can be optic nerve compression with central retinal artery or vein occlusion. So let's take another question now. All of the following are clinical features that help you differentiate preseptal from orbital cellulitis. This is another important question, differentiating preseptal from orbital cellulitis. Lid edema, so it's present in both, so it cannot be the right answer. Proptosis, yes. Orbital cellulitis will have proptosis and preseptal will not. Chemosis will have, there will be chemosis in orbital cellulitis and restricted ocular motility can also be expected in orbital cellulitis. So lid edema is common to both, so you cannot use this as a criteria to differentiate between preseptal and orbital cellulitis. So the right answer here is A. Okay, so what are the differences clinically that you want to see between preseptal and orbital cellulitis? So there is symptoms wise, there's less pain and swelling, no fever. Orbital cellulitis, the pain tends to be more, fever might be there. So this is not only criteria. More objective signs are lithedema, which is a little boggy in preseptal and it's very hard and woody in orbital cellulitis. Movements are absolutely normal in preseptal, whereas movements are restricted and are painful in orbital cellulitis. There is no proptosis in preseptal cellulitis, but proptosis starts developing in orbital cellulitis. So the optic nerve components, vision, pupil, color vision, everything is normal, but these might get affected in orbital cellulitis. And conjunctival congestion is there in both, but chemosis indicates that there is a increased orbital pressure caused by orbital cellulitis. So posterior segment is usually normal in preseptal cellulitis, whereas the disc can be edematous in orbital cellulitis. So the treatment needs to be more aggressive in orbital cellulitis with a hospital stay, and oral steroids may be started under the cover of antibiotics. So the complications are very few in preseptal, whereas they are more in orbital cellulitis. Ethmoidal sinus is most implicated as a cause of orbital cellulitis. Why? It is the most commonly involved sinus in sinusitis. No. It is closest to the orbit. All sinuses are close to the orbit. It is separated from the orbit by a very thin bone. Yes. So this is known as lamina papracia. So we have read this again and again. So it's an important point. So I am bringing it forth in many ways. Okay. So it's in direct contact. No, there is a bone that separates the two. So the right answer here is C. So the ethmoidal sinus is the most common cause for orbital cellulitis because there is a very thin bone that separates the orbit from the ethmoidal sinus. A 78-year-old male presents with pain and swelling of the right eye. On examination, globe was laterally and anteriorly displaced. So they're saying there's eccentric proptosis with conjunctival congestion and chemosis. There is restricted adduction. Okay, so you have a patient with signs of orbital cellulitis, but there is an eccentric sort of a proptosis. Okay, the CT scan of the orbit is shown in the following image. So it's something that's glaringly looking at you. Here is the abscess. Can you see this periosteum, the periosteum being elevated, and this is the subperiosteal abscess. That is why you are getting an eccentric proptosis and limited adduction. So we all know the right answer. This answer is subperiosteal abscess. Okay. Okay. Let's move on to cavernous sinus thrombosis. Cavernous sinus is a paired venous valveless space situated in the middle cranial fossa on either sides of the sphenoid bone. So let's look at the relations here. So this blue color is the cavernous sinus. Can you see they are connected to each other by a small communication there? So superiorly we have the optic chiasm and the internal carotid artery. Okay. On the medial side you have the nice pituitary gland and the sphenoidal hair cells. Laterally, you have the temporal bone of the temporal lobe of the cerebrum, and inferiorly, you have the foramen lucidum. So, what are the contents of the cavernous sinus? So, in the wall, lateral wall, you have the third, fourth, sixth nerve, V1 and V2. So, ophthalmic and mandibular, mac maxillary and mandibular nerve. And then we have V1 here, V1, V2, and V3 is actually outside the cavernous sinus. So you have the ophthalmic and maxillary nerves here, and you have the abducens nerve within the body of the cavernous sinus. Okay. So cavernous sinus thrombosis, how does it present? It's usually a very acute condition. It presents with unilateral or bilateral, and soon it becomes bilateral. The patient is usually toxic and there may be features of septicemia. There is severe pain on the affected eye with conjunctival congestion, chemosis, and marked proptosis. Paralysis of the abducens nerve begins first because it's present within the substance of the sinus. It's usually then followed by third and the fourth nerve palsy. There is a loss of sensation in the region supplied by the ophthalmic and the maxillary division. Okay, so there is total ophthalmoplegia with loss of sensations. Okay, there might be an edema on the mastoid region due to the back pressure from the emissary veins, and there might be visual loss in later stages due to the compression of the optic chiasm. Okay, so what are the complications? Meningitis, septicemic shock, and death. So to understand what can be the particular etiology that is causing cavernous sinus or how the infection travels, you need to know that it is a very well connected sinus. So let's understand the connections as tributaries, draining channels, and other communications. So from the orbit, you have the superior ophthalmic vein, inferior ophthalmic vein, and the central retinal vein that enter the cavernous sinus. From the meninges, you have the sphenoparietal sinus and mediomeningeal vein that enter the cavernous sinus. From the brain, you have superficial middle cerebral vein and the inferior cerebral vein. So these are the tributaries. Okay. Then draining channels, we have the superior petrosal and the inferior petrosal sinus that drain from the sinus into the sigmoid and the transverse sinus posteriorly. Communications, it communicates with the facial vein through the emissary veins which pass through the foramen ovale and the pterygoid plexus which communicate later with the facial vein. Then you have the basilar plexus of veins which communicate with the internal vertebral venous plexus. So, how from what are the sources of infection and what are the common infections? Anteriorly, you have the superior and the inferior ophthalmic veins, which drain the area of face, nose, paranasal sinuses, and orbits. So, facial infections, orbital abscesses, and furuncles and sinusitis can cause infection to spread backwards. Posteriorly, you have the superior and the inferior petrosal sinus. So, this transmits infections from the middle ear and the mastoid air cells. So, suppurative otitis media and mastoiditis can also lead to cavernous sinus thrombosis. So, there are connections between the either sides of the cavernous sinus. So, that is why it tends to be bilateral very soon. Then superiorly, the veins of the cerebrum drain into the cavernous sinus. So, meningitis and cerebral abscesses can also lead to cavernous sinus syndrome. Inferiorly, we have the pterygoid venous plexus, which transmit infection from the tonsillar region. So, peritonsillar abscesses can also cause cavernous sinus infection. So, what is the treatment of this condition? It is an emergent condition and the patient has to be hospitalized. He has to be monitored for the development of sepsis through serial blood counts and cultures. Identify the source of infection and treat it if possible. Then intravenous broad spectrum antibiotics like vancomycin, third generation cephalosporins and metronidazole should be given for a very long time, like 3 to 4 weeks. Steroids, questionable. Some people have got good results with it. And the antibiotics have to be continued for 2 more weeks even after the symptoms have subsided. So we have a 55-year-old diabetic lady here with a 55-year-old diabetic man with a furuncle over his philtrum, which was treated with local antibiotics alone. However, after 4 days, he develops fever with chills and protrusion of his left eye with redness and pain. On examination, visual acuity is 6/6 and N6 in both eyes. Left abduction is restricted and there is axial proptosis of just 3 mm. Conjunctival congestion and chemosis is present, and MRI of the brain shows the following image. So you have a patient with uh, a source of infection on the face, which was treated just with local antibiotics, and now he has constitutional symptoms with proptosis of one eye associated with all other findings. So probably are dealing with a cavernous sinus, and they have shown a MRI image here, which shows MR angiogram that shows filling voids within the. So the MR angiogram shows here the filling voids within the cavernous sinus, suggestive of cavernous sinus thrombosis. The right answer here is C. So let's move on to orbital mucormycosis. It is a life-threatening, site-threatening fungal infection of the orbit, usually seen in debilitated patients post-renal transplant on steroids or immunosuppressants and who have uncontrolled diabetes. So the pathogenesis, it is almost considered as a commensal within the nasal cavity and the sinuses, and the infection spreads due to the fungal spores that invade the uh, tissues. Okay, so this invasion requires some amount of immunosuppression from the host site. So once they start invading tissues, they enter the orbit through the inferior orbital fissure by the direct destruction of bone and soft tissue is also another way in which it can invade the orbit. After eroding all the structures in the orbit, the infection spreads into the intracranial cavity, which causes more pronounced problems. So there is usually a rapid progression of symptoms and signs within days and hours. Initial symptoms are painful restriction of one or two eyes and usually eye movements with mild chemosis. There can be mild edema alone. So pain and proptosis increase with further restriction of eye movements. You can, if you're lucky, you can see necrotic areas with black scar that on the mucosa of the palate, turbinates, nasal septum, and the skin of eyelids. So soon a picture of orbital apex syndrome develops, and if not treated energetically, you can land in trouble. So we have a 50-year-old diabetic woman post renal transplant on oral steroids is admitted for control of sugars. During her stay, she develops proptosis, emesis, restricted movements of the right eye. In the next 24 hours, there is restriction of movements have worsened. The pupil is now dilated and she has severe ptosis. So this is showing that there is total ophthalmoplegia. There is loss of corneal sensation. Nasal examination revealed necrosis of the nasal cartilage and there was an scar that was seen. Pick up the false statement regarding this case. This is an orbital apex syndrome. Clinically, yes. So probably we are dealing here with orbital mucormycosis, also known as ROCM, rhino-orbitocerebral mucormycosis, to be very specific. So biopsy of the lesion will remain septate fungi. It will reveal fungi, yes, but they are not septate. They are aseptate. So rhizopus is an aseptate fungus. Treatment is in the form of surgical debridement and exentration of the orbit, correct? Death can be due to spread of infection to the brain, correct? So the right answer here is B. So it will reveal aseptate fungi. A 27-year-old presented with painful swelling of his left eye associated with restricted abduction. Orbital ecography showed a cystic lesion of the lateral rectus with a hyperechoic center. So a cyst like this with a hyperechoic center like this, it usually signifies a scolex, usually seen in infestation with tinea solium, and this is known as orbital cysticercosis. Which of the following does not help in managing the case? You want to rule out stool examination for X? Yes, it will help because that's how the worm has entered the body. Systemic albendazole, yes. Radiation, no. Oral steroids, yes. So albendazole is the mainstay of therapy for around 4 weeks along with systemic steroids to control the inflammation. Radiation is not at all recommended for cases of orbital cysticercosis. So this is about infectious orbital inflammation. So we'll continue with non-infectious orbital inflammation in the next week. Thank you.